All right, guys, chapter 17. Curtis again. This is going to be our pediatric emergencies for our EMR class. Let's talk about some pediatric emergencies. Now, as you can imagine, with kids, they're not going to be a whole lot different as occurrences go. Infants, children, all ages, adolescents, everybody is going to have some sudden illness and medical injuries. They're still going to get hurt. They're still going to fall down and go boom, all of that. But thinking about that, they still see some of these common injuries. There is some distinct anatomical differences between adults and children. So, having that knowledge and then knowing a little bit different skill-wise is going to help you to be able to assess and then treat those children appropriately. So one of the big things that you see for kids and for really all ages of kids is respiratory care. So especially with babies and infants, respiratory care is going to be one of your biggest things. That really starts to negatively affect and negatively impact small children. So respiratory care is a big piece of the puzzle here. So you're going to need to learn as EMRs, we want to learn some basic information and treatment just for some common pediatric emergencies, and that's what we're here to do. So, managing these can be, if you haven't been in a emergency situation with a child, with a pediatric, it's of course very stressful. For some reason, it seems to be a lot more stressful than with most adult situations. So you need to think about that. Prior to that that's why we talk about building that systematic approach to patient assessments, is because when we get in these very stressful situations, just that motor memory, muscle memory, all of that takes over and we still do a good job. So when everyone involved is going to be tense in these kind of atmospheres, we need to be able to remain calm and behave in a controlled, and professional manner. So it can be a little bit challenging. EMS personnel, they often have mixed feelings when treating a child because there's so much anxiety and so much tension and just stress and anxiety involved that it can definitely start to affect the medical care that is given. Now, the parents can be a big help for you here. Parents can be allies or they can be a potential problem. So they can help you with things or they can start to really hinder things. So we want to make sure that we talk to both parents and children together as much as possible. Helpful parents, they can tell you how the child's behavior is different from their usual behavior. They can get many of their behavioral cues from their parents. When if you've never been around babies very much, when mom or dad is startled, it can scare them. When they pick up a lot of their behavioral cues from their parents. So calm parents, make sure that we calm the parents, and then ask for their assistance in calming the child. And if possible, if the scene allows it, and your protocols permit it, we want to let the parent hold the child. That will help calm down the child in the event that they're a little bit, out of control or something. So we want to make sure to try to develop a rapport with these patients, obviously with mom and dad, but with the child as well. So if they're at the age of able to understand things and process information, make sure you introduce yourself. Make sure you use the child's name. We want to squat, kneel, or even sit down so we can establish some eye contact so you're not standing over them, kind of as a position of authority. And make sure that we ask just some simple questions that they're going to be able to understand. We do want to be honest with children. I've said it before. We do not want to say this isn't going to hurt and then it hurts, because they're not going to trust you again. So be honest with the child. Explain to them what you're going to do. Explain that it might hurt. Maybe just tell them, it feels like a little bee sting or a little stick with a pin or whatever, in the event that you're going to poke them with something. So, you want to be honest with them. When you can have them help you, that's going to be a big thing. So if you can request their help while you're talking to them, that's, hold this for me or look at this or whatever you involve them, that's going to help build that rapport. And sometimes, as you see in that picture, some agencies may have some teddy bears. If you're at a very small service and you don't have stuff like that, a lot of times some local vendors like the Walmarts and stuff and those kind of stores, they will come alongside of you and donate some of those things for the kids. many times you just have to ask. As EMS providers, we think that the community doesn't want to get involved. The truth of it is we haven't asked them to come alongside of us and get involved. So sometimes if you'll go out and ask those questions, you might be surprised by your answers. Now, anatomy and function, pediatric anatomy and function. So children and adults, they have the same body systems. They perform the same functions, but there are some big time differences. You can see in this picture here where we talk about this child's tongue and the adult tongue. That first off, the airway is smaller in relation to the rest of the body compared to an adult's airway, but the tongue is proportionally larger. So you see, how much larger in proportion to this airway this tongue is versus the adults. So, the whole thing is that it's in relation. So that's a big part of that. It's more easily blocked by secretions or swelling when we start talking about this airway being smaller. We start talking about the trachea being smaller. It's much easier to be blocked. So we talked about the tongue, it's proportionally larger. Well, by the same thing, it can block the airway as well. So, those are some of those differences that we need to be able to think about. Now, a child's airway, it's more flexible than that of an adult. So one of the things we want to make sure is we want to avoid hyperextending the neck when we're attempting to open the airway. Sometimes people get in a bad habit of just hyperextending the neck on a patient, of just cranking it back. On a kid, we'll just completely shut down the airway by doing that. What we want to do is position the head in a neutral or even a slight sniffing position. Now, with these kids around the first 6 months of their lives, the infants, they can breathe only through their noses. So they're, obligate nose breathers. That's how they breathe. So if they get a junky nose and they've got snot and all that, it will really affect their oxygen exchange and how they're able to get air into their lungs. And when a child's respiratory system, when the demands cause some change within the respiratory system, the child is able to quickly compensate by increasing their breathing rate and their effort. So they're able to pick up their rate so they get more and more air in to compensate for the decreased amount of air that's coming in. They just breathe more trying to get the same amount. But that compensatory mechanism, that's kind of fixing the equation of getting enough air in there. That will eventually wear out. It's only good for a short period of time. So what we might see is that child could show some signs of severe respiratory distress, and when that starts happening, they can rapidly progress to respiratory failure. Children are known for compensating very well, kind of up to a point, and then once they reach that point, they're done. So you can we've talked about it for years in EMS and kind of related it to a cliff that, everything is just going fine. Everything is going fine. But when you get to the edge of the cliff, it's not fine. It's just an immediate drop. Typically with kids, you don't have that slow progression like you might with an adult to where it just over time, it becomes an issue. They do not compensate well at the end. They compensate very well. They have very, vigorous reserves. But at the end, they're done. So make sure we do perform a thorough assessment. We want to recheck the vital signs for these kids, every 5 minutes. Now, as we mentioned, these infants and children, they have limited abilities to compensate for changes in temperature as well. We talked about that compensation, but for temperature, they have limited abilities, comparatively speaking. So children lose relatively more heat than adults do. So we need to make sure that we keep those pediatric patients warm if they start to become chilled. Now, when examining a child, that consists of the same 5 steps that we talk about within patient assessment sequence for adults. So the same scene size up, a primary assessment, general impression, determining the responsiveness or level of consciousness, assess the ABCs, secondary assessment, that medical history, perform reassessments as needed, same pieces of the puzzle. Now, this is a really important slide, in my opinion, probably one of the most important ones that we can show you. What I suggest is you almost start relating this to adults as well. So this pediatric assessment, or the PAT, pediatric assessment triangle, what it does is helps you to quickly form a general impression of that child using only your senses of sight and hearing. So what you can do is essentially this is to be used when you first walk in the room or when you first lay your eyes on this child, is you look for these particular things, and then it kind of gives you an idea of what I like to term as just sick or not sick. You can start to do that for adults as well, though. When you start to kind of cross-reference this, when you start to kind of compare it to adults, you can use this same assessment triangle with adults. So what it does, it provides you with an accurate initial picture of functioning of the child's airway, of their breathing, of their circulation, and then their level of responsiveness or their level of consciousness. So it can be used to assess from the distance and determine which steps need to be taken first. Do we need to, worry about their circulation or worry about their breathing? We're looking at all of these different things and able to process this. The appearance, work of breathing, and then as you see, circulation to skin. So when we talk about appearance, that general appearance, it's an indicator of how well the heart and the lungs are working. It allows us to kind of just get a quick little general idea if things are going good. So appearance is also a good indication of how well the central nervous system is working. And then we can compare the child's appearance and actions with what you would expect from a healthy child to what we're seeing. It needs to be of the same age, but you just start kind of comparing of what you're used to seeing versus what we're seeing now. Now you want to assess their eye contact, their muscle tone, skin color, all of those kinds of things that you notice about kids when you first start looking at them. So a child who's not crying, that can be a problem. They might have a decreased level of consciousness, maybe an upper respiratory or upper airway infection, or maybe even some swelling in their airway. Now, a child who is unresponsive, obviously they're going to be lackluster, appear ill. When you start to see that, that should hopefully be a red flag for you. We need to evaluate them very carefully because this is not the normal thing, obviously, And then we reassess a child's appearance regularly because it can change very quickly. Now, here is just kind of some characteristics of appearance, movement, healthy versus unhealthy. So you see we have moving vigorously. That's what we're hoping for and expecting. This is the unhealthy. So limp, listless, flaccid. Interaction, reaches for a toy or reacts to a person, uninterested. Reassurance, they're reassured by caregivers, or they just don't care and they're crying or agitated, is the unhealthy. Eye movement, they follow the person or a toy. Glassy-eyed stare. That's a big one. That, when you see a kid that maybe has meningitis or some kind of weird infection, they just have this kind of glassy-eyed stare that's just not paying attention to people. Within speech, age appropriate. That's a big part, is age appropriate, or is it just confused? And then a strong cry versus a weak or high-pitched cry. So those are kind of what we're expecting, those characteristics of appearance. So now we move on to breathing, characteristics of the work of breathing. So assessing work of breathing is a more accurate indicator of a child's condition than merely determining just their rate of respiration. So just because they're breathing 22 times doesn't really mean a lot. What we're looking at is their work of breathing. Are they, if they're struggling, if we're hearing weird sounds and all of that. So the work of breathing, we look at 4 factors. What you see is abnormal breath sounds, abnormal positioning. So, are they holding themselves in a weird way to be able to breathe better? Retractions of the neck or chest, and then flaring of the nostrils. Those are the kinds of things that we're looking for when we start looking at the characteristics of work of breathing. Assessments, they can be made without touching this child and can be done from across the room. That's the beauty of this thing. Right away, we're processing this information as we walk into the room and look at our patient, and we start to quickly develop the sick or not sick idea. And remember, I'm quite certain I mentioned it, but sick versus not sick doesn't mean someone's not sick. It means are they going to potentially die on you? That's what we're saying. So critical or not critical. If you're there, they've probably decided that they need to go to the hospital, and so we're going to call them sick by definition. But what we're talking about when I say sick or not sick is going to be, are they going to die on you or have the potential to die on you within the next however many minutes? And now we move on to circulation to skin. So characteristics of circulation to the skin. So we want to look for characteristics, and we start determining the circulation. So we look for paleness, white or pale skin. That indicates inadequate blood flow to the skin. And then you can start to look for also like some patchy skin discoloration. That's caused by too much or too little circulation to the skin. And then we have cyanosis, so bluish discoloration is caused by low levels of oxygen in the blood. So each one of these kind of skin condition things gives us an idea of what might be going on. Now this PAT, this Pediatric Assessment Triangle, it should be used with other parts of your patient assessment sequence. So all of the thing that we talked about at the beginning, those steps, we're going to just throw this in there with that. Now respirations. You see to calculate, the respiratory rate of a child. Count the respirations 30 seconds, and then, of course, multiply it by 2. Children, they breathe so fast and can kind of be irregular. So just doing it 10 times, for 10 seconds and then multiplying, that's not going to be a really accurate picture. So 30 seconds is a long time, but it gives you a much more accurate representation of what's going on. Now while we're doing this, we're looking for signs of respiratory distress. So what I mean by that is we're assessing how much work that the child is doing to breathe. We're listening and looking for abnormal breath sounds. So what I mean by that is, do we see noise or hear noisy breathing, snoring, crowing, grunting, wheezing? Your book talks about those, but are we hearing those? That's kind of what we're looking for, is some of those abnormal breath sounds. So we want to determine whether the child is holding himself in an abnormal position, where I talked to you about how they're sitting. If they're sitting in a weird position that doesn't seem very comfortable or normal, that might tell us something's not quite right. We want to look for retractions of the neck and chest, and then those flaring of the nostrils as well when we talk about respirations. Now the pulse rate you see right there, that's going to be the brachial pulse. That's where we're going to take it on these little ones. That's the best place to take it, is over that brachial artery. Of course, directly over the heart also, if you're listening through a stethoscope. But the normal pulse rate of a child, it's obviously going to be faster. Maybe I shouldn't say obviously, but it's going to be faster than an adult's normal rate. So a child younger than 1, this is what we talked about. This is where we're going to take it. You're going to separate those two muscles, your bicep and your tricep, and push in and kind of pin down that artery, that brachial artery, to be able to get your pulse. So some vital signs. I'm not going to go over all of these, but take a good look at them. This is something that can be very handy if you're out running calls, that you have this just in a flip chart. So you can quickly have a reference guide. It's a lot safer for us to have it written down rather than trying to memorize it all. But you'll see, we did talk about how it's faster, 90 to 180. If an adult, point on my screen. If an adult is at 180, that's a real problem. That's some decreased cardiac output, and their color is going to be changing and all of that. That's a normal heart rate here. It's on the high end, but it's a normal heart rate. Same thing here. If respiration's 30 to 60, if we run an adult, just drop it in the middle at 45 breaths a minute, that's going to be a problem. So you see how all these start coming down and kind of start normalizing, to what we're used to for an adult. Temperatures. High body temperature. So those high temperatures in children, they're often accompanied by the flushed, red skin, maybe sweating, restlessness, they're just uncomfortable and all of that. So you want to feel a high temperature, then you can touch the child's chest and their head is where you'd normally feel it. What I would suggest is probably pull down your glove just a little bit and put the back of your hand just right on top of their forehead. Or their chest as well. Pull down your glove for a couple of reasons. One is that way you can feel it a lot better, in the case their skin is warm. Think about having your own baby though, and some, person came in and they had dirty gloves you don't know anything about, whether you just put them on or not. They don't know that. Mom or dad doesn't know that those gloves weren't just on you taking care of some other joker that just 15 minutes prior. They don't want you touching their baby with those, their face and all of that with those gloves. So just pull that down and get a good idea of their skin temperature. And now a child's heart rate, it increases with each degree of temperature rise. So we would expect if somebody has a temp, their pulse rate is going to increase. And we see that typically with adults as well. Now moving on to respiratory care. It's going to be important to open and maintain that child's airway and to ventilate them adequately when we find a child with any type of respiratory problems. So it's going to be important that we take care of these things. Problems, that respiratory problems and all that, They can quickly lead to respiratory arrest. And then once you get into respiratory arrest, now we're talking about cardiac arrest as well. So specific causes of cardiopulmonary arrest in children can be a number of different things. So suffocation or an aspiration of a foreign body, infections can cause that as well. SIDS, accidental poisonings, and of course injuries to children can cause that as well. So opening the airway, we're not going to go into much into this because you're going to do this in your BLS day, but want to make sure that you're squared away on your movement. So head tilt, chin lift, and all that stuff. We mentioned this. We mentioned not to hyperextend it. This is going to be kind of your neutral or sniffing. You can notice it's kind of extended. It looks like it might be extended up just a little bit. Think about when you hear the word neutral or sniffing, if you're unaware of what that word means, or at least what I think how it works, is when you walk in, you just return, whether you live with them or not, but maybe you go back to mom's house and she's cooking something, whatever it is for you that's amazing, a cobbler or an apple pie or some meatloaf or whatever, and you walk in and you smell it and you notice that you lift your head up just a little bit to kind of give your nose a little bit more room to take that smell in. That's going to be that sniffing position. So that's the neutral or sniffing position when we start talking about these kids. It's the same thing for an adult. Neutral and sniffing is for a kid, is for an adult, but it's not as detrimental to an adult if you do hyperextend their neck. It's not a great thing to hyperextend their neck when you're working on airway, but it's not so detrimental as it is to small children. So opening airway, trial thrust maneuver in the event you think there's a injury. As we've talked about before, BLS, use the heel of one hand or two hands to perform chest compressions, 1/3 depth of the chest. We're going to be going all of that into our BLS lab. Suctioning. So when a patient's airway is blocked by secretions, it might have some secretions. It could have some vomit or blood or whatever. You need to clear it initially by turning them on their side if you can, and then just use your gloved finger to kind of scoop that stuff out. When you're talking about some type of substance, not just some fluid. I'm not talking about just fluid, but it's whatever, something they were eating or whatever. You just kind of try to get as much of that out. Remember, no blind finger sweeps. You're not going in there blindly and pushing something else in there. But you can use suctioning to remove foreign substances that can't be removed now with that glove finger. So you're first trying to kind of scoop stuff out, then you can move on to suctioning. If you don't know it, suctioning can be a life-saving procedure. It's just a very basic, and at times it can be kind of yucky procedure, but because you're talking about something so important, as we mentioned, the ABCs, that has a chance to kill somebody. An airway gets clogged up from whatever, and you don't, let's say unclog it, you don't remove that obstruction, and that will end up killing somebody. So it may seem like just a very basic skill, but BLS, basic skills, that saves a lot of people. So the procedure used for suctioning infants and children, same as with adults, has a few exceptions. So you want to use a tonsil tip or a rigid tip to suction the mouth. Don't insert the tip any farther than you can see. Use a flexible catheter. We want to suction the nose of a child and set the suction on low, maybe medium power. This is all the kind of stuff that you want to follow however your service does it. Make sure you have a bulb syringe. We talked about that in our last with childbirth. Make sure you have a bulb syringe. You can get a lot of stuff out with that. You'll compress it and then allow it to suck stuff out. But after that, make sure you're squeezing stuff out, because the next time you squeeze that down, it's going to come out, whether it's maybe back in your patient's airway or on your leg or into a rag, a 4x4 that's where it's supposed to go. So use a bulb syringe. Never suction for more than 5 seconds at a time. What we're also suctioning out is oxygen. We don't want to do that. So by doing it at no more greater than 5 seconds, we won't suction out all of the oxygen out of the person's airway. And then try to ventilate and reoxygenate before repeat suctioning. So you suction them once. We need to try to give them a couple of more breaths and get them reoxygenated. Airway adjuncts. So oral airways, as we've talked about in the past, those things can help maintain an open airway after you've opened their airway by manual means. So there's a skill drill for that you guys will look at. And EMRs rarely use nasal airways for children. Now, talking about a mild or a partial airway obstruction. So usually relieve a mild airway obstruction by putting them on their back, tilting their head, and lifting the chin in the usual manner. So make sure that you pay attention to just looking at these slides, because it's going to be the same as in your BLS class. But I don't want to go over this because you're going to do this in lab and watch some videos, and it just feels like we'd just take up a lot of time. Now, we will talk about this complete airway obstruction. What does that mean? So when we start talking about these kids, that airway obstruction, serious emergency, and a severe airway obstruction exists when you have poor air exchange, increased breathing difficulty, silent cough, the inability to speak, or all the way up to and including no air movement. That's going to be a complete airway obstruction. How we're going to fix that with kids, with larger kids, abdominal thrust, so the Heimlich maneuver. And then with little ones, we're going to do back blows and all of that with little infants. Infant is very fragile, but unfortunately you do gotta kind of, for lack of better words, you gotta kind of whack them a little bit hard on their back to get that stuff out. You're building that pressure up to allow whatever it is that's in there out. Now, if the infant is crying, the airway is not completely obstructed, so that's where we'll need to start thinking about, what maneuver are we doing? So an infant, younger than 1 is what we're talking about. And you see here we're talking about back blows, back slaps, and chest thrust maneuver. You guys will do this in class. And like I said, I just don't want to completely go over stuff you're already doing. Swallowed objects. So if they swallow small round objects, they usually pass uneventfully through the child. Going to go with them as in their bathroom procedures. But sharp or straight objects, they are dangerous, as you can imagine, if they're swallowed. So respiratory distress, signs of respiratory distress, what does that look like? And respiratory distress, it indicates that a child has a serious problem and it requires some immediate medical attention. That's what we're talking about. So some of that looks like a breathing rate of more than 60 per minute in infants, a breathing rate of more than 30 to 40 per minute in children, nasal flaring on each breath, and then retractions of the skin between the ribs and around the neck muscles. Also stridor, which stridor is like an inspiratory wheezing. So if you hear wheezing when they're breathing in and breathing out, that's not good as well, but that's what we're talking about, is stridor. Cyanosis of the skin, so skin color changes, altered mental status, they're not acting right, they're combative or restless. Those are all things that are signs of respiratory distress. So the treatment, we want to find out what the cause is. Do we need to give them some more oxygen? Do they just need oxygen, or do they have an airway obstruction, or what is the cause of this respiratory distress? Maybe it's some type of allergen, who knows? But we need to support their respirations as well by putting them more into a comfortable position, kind of usually sitting, allowing them to just try to hopefully breathe normally. Keep them as calm as possible, and then get some oxygen on them if you're able to. Monitor their vital signs, and then obviously make sure they're going to the hospital with whoever it is they're supposed to go with, whether it's you or them meaning EMS. Now, respiratory failure. It often results as respiratory distress proceeds. So respiratory distress starts the things, and then it just keeps progressing into respiratory failure. And what we're talking about is that breathing rate of fewer than 20 per minute in an infant, and a breathing rate of fewer than 10 per minute in a child. They'll have limp muscle tone. They're just going to be flaccid and what's the right word, rigor, or not rigor, but no stiffness to them. They're not going to be working, no activity. So they're going to be unresponsive, decreased or absent heart rate, weaker absent distal pulses. So a child in respiratory failure, as I mentioned before, respiratory failure starts, and then eventually they end up getting into cardiac failure as well, or cardiac arrest. So our treatment, support respirations by doing some ventilations, administer O2 if you have that, begin chest compressions if the heart rate is absent or less than 60, we're talking about these infants, arrange for prompt transport. Circulatory failure. So circulatory failure, the most common cause of circulatory failure in children is going to be respiratory failure. Before I said everything goes back to respiratory. We really need to think about that's how important respiratory failure is. Most common cause of this, of circulatory failure, is respiratory. So it plays a really big part in this. So uncorrected circulatory failure, it can and will lead to cardiac arrest. So increased heart rate, pale or bluish skin, changes in mental status, those all indicate circulatory failure. So if the heart rate is more than 60 a minute, we're going to do that patient assessment sequence. We're going to support some ventilations if they're needed. We're going to put on O2. We're going to get some vital signs. Now, if the heart rate is less than 60 and there are signs of poor circulation, we're going to begin chest compressions and rescue breathing. All right, here's where we'll stop, and we'll pick this up on the next one.